We are here in Mumbai, and my name is Dr. Abad Khan. I am an interventional cardiologist currently practicing at St. Joseph Hospital, Ghaziabad. Today is 11th October, and we are on day 2 of the CRISP TV. It's beautiful here, and we have an international faculty guest here with us, Dr. Professor Kedhi Elvin. He is a director of interventional cardiology at McGill University, Montreal, Canada. He's also a visiting professor of cardiology at Salesian Medical University in Katowice, Poland. Sorry if I pronounce any of them wrong. Welcome, Dr. Elvin.
Oh, nice to meet you here.
Yeah, nice. We'll have a, so first question is, how have you been practice different after the Recage-free 1 and PREVENT trial? Or have you always been a believer of treatment of high-risk vulnerable plaque after your data come on combined OCT FFR study that you published way back in 2019?
Yes. Well, that's a beautiful but also difficult question to answer. There are different facets on how we see vulnerable plaque. And why I personally believe that we, in a way, need to treat the higher risk plaques. It is crucial to really being able to identify them. Now, coming to the PREVENT trial, it was the first step which showed that probably treating some sort of vulnerable plaque, I will not call it vulnerable plaque immediately because the criteria for enrollment in this trial were so wide that mainly 98% of lesions, more than 50%, would already fall into this category of lesions that need to be treated, which absolutely is not necessarily to treat. However, there are some lesions that are 50% or let's say non-ischemic that might deserve treatment. We don't have that evidence yet. We know that this kind of plaque is really dangerous, and it's sometimes 10 times more dangerous or have 10 times more higher event rate than what the actual event rate with a stent is now. Now, one good thing that PREVENT trial did show was that the stent rate, event rates are absolutely low.
Yes.
Maybe this is lower than what we have seen in other trials. In other trials, we see around 4% MACE rate or a target lesion failure rate at a year or 2 years. This was particularly low, but however, of course, now that we're using more and more imaging during the procedures, these rates are becoming low. And it's also true that when you have this low risk lesions, the event rate of treatment of this is absolutely low. So it is indeed very low. So if you compare with the event rate that if you leave these kind of plaques untreated, that is really high with some type of event rate varying from 10 to 50%. So you could see the scale of the difference that we can observe. Of course, what remains crucial is what is vulnerable plaque. And I will invite you later to my lecture because that's what I'm talking about. But the vulnerable plaque is not a yes or no. It's a continuum. And it depends on large, let's say, a combination of one major factor that is a thin cap fibroadenoma that is a requisite to have a vulnerable plaque, together with other factors like a TICFA in combination with a healed plaque means that there is history there, yeah, and that is repeating itself. So there is a propensity. There is a minimum lumen or a plaque burden, means that this plaque has reached a sort of critical stenosis, which may not give you ischemia, but it's at least 50% or translates to a plaque burden around 70%. So that is the kind of plaque that is dangerous. With the nucleus core, with the TICFA, with signs of previous rupture of healing, and still presence of inflammation in the form of thin cap fibroadenoma of the nucleus core. So if you have these factors together, then of course, depending on the number of these factors, then you'll have a higher event rate for these kind of plaques. Do we have evidence to treat those? Yeah, no, not yet. But I think that PREVENT includes those types of plaques. But we are doing now combined intervene, and that we have finished enrollment already a year ago, and we're looking to have one more year to wait before we could have the results. And hopefully then we'll have the evidence together with another trial that is done by my colleague, Professor Prati in Italy, and another one again done in Spain. The combination of these three trials, which are looking to, let's say, more focused and more classically defined vulnerable plaque than the prevented, and by use of OCT, which has made a crucial difference in being able to identify vulnerable plaque, then we'll have some more evidence.
Perfect. So you are treating and trying to treat some things and some of the plaques which may have a more event rate, but the data is currently not here. And Dr. Kelvin, Professor Kelvin, is trying to find out with his new trials also coming up. So that is absolutely wonderful. Also, sir, with the current growing data on the safety of the lithotripsy vis-a-vis other calcium modification devices like rotablation and orbital atherectomy, do you see in future, with the advent of new generation lithotripsy device with a better profile, with the forward modification techniques, does the calcium modification will mean only lithotripsy or only bailout as rotablation will be needed? So how do you see this?
Also another good question. I think there is a role for all of them. I don't think that the rest of them will be bailout. You have to understand that lithotripsy is a beautiful technique and helps a lot. However, you need to realize that there is calcium and calcium. And there are some type of lesions that you will, now that we've been using lithotripsy a lot, we're seeing also where it fails. And in my opinion, it fails in some sort of calcified, eccentric, nodular lesions. In the end of the day, you see that you could actually crack this calcium, but then not so efficiently. And that despite you could achieve some expansion that looks good initially, you'll see that this will come back. So I think that for heavy and long lesion calcifications, I think that new tools like orbital atherectomy in particular are important. I'm saying orbital and not rotablator. Rotablator is also a fantastic tool, but it's limited to the volume that it generates, the amount of lumen that it generates, that can go up to, normally what we use is 1.5 Bird. So if you want to still work via radial, then that's what you get. It's 1.5, and sometimes this is not enough. While the orbital, especially if you use a higher speed, will obtain very good lumens. And in some sort of lesions, this is what is actually giving me the best results nowadays. So coming back to your question, I don't think that that these will be a bailout. I think that some of them, especially for certain type of lesions, will be used as standalone techniques. That said, IVL still is a very good tool, particularly if you just have some focal lesions with not extremely very calcified lesions, then you can just obtain better lumen just by using this. But there are other players in the field like, I don't know, OPN balloons or so on that also could give a very good result sometimes.
Perfect, sir. So advancement in one of the technologies does not have to come at the cost of decrease in usage of the already established ones. Rotablation and orbital atherectomy remains standard of care for diffuse diseases, diffuse calcific superficial lesions, and obviously advancement will have, and as Professor Elvin said, that each have their own role. I'd just like to elaborate on one of the point. Do you think that the orbital atherectomy usage will remain as good as has been even after the Eclipse trial?
That's also another question. I think that the criteria of Eclipse trial were maybe a bit broad. And there is another thing that I have started to understand now that I've used a lot of orbital atherectomy. You have to realize that this trial was done when this technology was just brought out. And a lot of operators, while being still very good operators, you need a learning curve and to really understand how this technology works. And I'm speaking also for myself because I'm using this technology now for about a year and a half that I'm using it myself. And I can see the difference that I have between the first procedures and the second procedures. And it's crucial to understand how this technology works. And once you've used it, then you really understand it. And it is very important to actually control with imaging step by step what you're doing, and if you are obtaining a really good result. You use it not correctly, then you have just the same result as a rotablator, which will not give you a big lumen. You need to really use it correctly in order to obtain the benefit of the circular orbital function, which then will generate you bigger lumens. And the crucial thing is to look into your image to obtain calcium thicknesses of less than 300 micron or around 300 micron, which are modifiable with then all non-culprit balloons. And then you have done a really good job, because then you could obtain really the really largest lumens. If you don't do that, then the effect is less. So I think we still need some more trials. Absolutely believe that we need more trials, particularly in certain type of calcium morphology, which are really where the IVL or other techniques are not so efficient also, to see where the benefit of this technology. So I don't think that, in my opinion, it has not really changed much my experience. I still use it in combination sometimes with other, but the beauty of this technology is that it's a standalone technique, and also it saves you sometimes. You don't need an orbital and an IVL and a lot. It saves you time actually, and sometimes it's financially also beneficial.
Perfect. All the things, all the consideration we are doing to help the patients and to actually have an effect on the outcomes also. So one trial may not be the best, to put it that way. How important has imaging become, even more so now with the rise of the drug-coated balloon strategies?
Well, imaging for me is very important for different reasons. I think that I already said it, imaging is very important for, especially it's now also reflected in the guidelines, because it's life-saving. It reduces mortality in complex PCI, but as I also told you before, it's also important into understanding the morphology and the danger of the plaque that you are treating. And so I am, like I think a lot of other people, a huge partisan of working image guided, and I claim that I'm an OCT user simply because it's simple. It's much simpler than IVUS, and it's easy. I mean, you've done one or two, then it's easy to understand. It speaks for itself. So now we have now more than one company producing OCT. There will be a lot of development into this too. And we'll have combined OCT IVUS, OCT with lipid detection and so on. And I think that the field will be very important. Now, coming back to your question about drug-eluting balloons, yes. I don't think that it is super important on drug-eluting balloons, and it is, of course, like for all other reasons, but my use, I don't know, of drug-eluting balloons, I think it's a major hype, and don't get me wrong, there has been a major advancement in this technology. It's a beautiful technology, and it's a technology that will definitely have a huge future, but we still need data for larger vessels, because right now I think I use it personally sometimes in a situation I cannot put a stent for various reasons, instant restenosis or small branches and so on. I still am not 100% comfortable, because we're missing the data. Actually, we're not missing the data. We have the contrary data that in larger vessels, the stents, actually drug-eluting stents, are better. Now, I also am a partisan of not leaving anything beyond, but we have to not forget why the drug-eluting stents in general, then drug-eluting stents were introduced, in order to understand that we also need scaffolding at a certain point. And by saying that, I think that there is a future. I think that the combination in the future, the way I see it, is that for larger vessels, we'll have bioabsorbable scaffolds, or I don't know how we call them anymore now, but like BVS-like solutions, and for smaller or intermediate vessels, or sometimes some sort of events that we're not comfortable of using stents, like maybe plaque erosions, we could use drug-eluting, drug-coated balloons. Yeah.
Perfect. So he has perfectly placed his and also shared his vision also for the future, that what in future lies for us. For him, for Professor Elvin, imaging is mandatory. Whether you're doing a drug-coated stent, drug-coated stent, or drug-eluting stent, or a drug-coated balloon, imaging is mandatory to understand the lesion, and that is how it should be, and that is what the guidelines say actually. You also have some of the experience with bioabsorbable also, you just mentioned. Do you feel that the drug-coated balloon will be have better long-term outcomes if we are able to find a good bioabsorbable stent with excellent short-term outcomes also in regard to stent thrombosis and the stent areas?
I didn't understand very well
Okay,
your question.
so the idea is we just want to have a knowledge. Do you have, because you have some exposure to the bioabsorbable stents also, so if we have, the data is coming up with some of the manufacturers producing newer generation of bioabsorbable stents. Do you feel that that is the future vis-a-vis drug-coated balloons? You've already partially answered that in the previous question.
Yeah, I think I already mentioned. I think that for larger vessels, we definitely listen. The situation is that we have. I don't think that there are different lesions, of course, and I think there will be different indications. The reason why BVS, the BVS that we had before, was sort of not bringing very good results is, in my opinion, because it was in the hype and enthusiasm of the time, there was a lot of use of this device in indications that are probably not good for a polymer stent. And that is, let's say, a lot of calcified lung lesions. I think that there will be still a place for the actual drug-eluting stents as we have now, which have the sort of radial force and the sort of, let's say, mechanical properties that will be good for treatment of some calcific lesions. And maybe there will be some calcific lesions that will do good on drug-eluting balloons after some modification, calcium modification. In my position, I think for large vessels and some indications of acute but relatively soft plaque, that's where I see the future of bioresorbable stents, and also for treatment of vulnerable plaque.
Yeah.
And while the drug-eluting balloons, I think, will still have an indication for, I don't know, smaller size vessels and side branches. I think that, and maybe some indications where the plaque burden is not so big, so you just need some opacification of the lesion and so on. But that's my opinion for the moment, and maybe I'm completely wrong, and that time will prove me wrong. But that's the way I think at the moment. Yeah.
That is what it should be. The foresight has to be there, but the use has to be data driven, and that is what Professor Elvin is saying. How does Mumbai feel, sir, and how have you been finding the CRISP 2025 conference?
Oh, it's a beautiful atmosphere. I see a lot of beautiful lectures, a nice venue. It was a pleasure to be here, and I'm continuing to have this pleasure. I have a full day today, so I will answer better this question in the end of the meeting.
Perfect, perfect. Thank you so much, sir. And that is, we'll have some. That was great talk with Professor Elvin, and see you in the next video. Thank you.
Thank you. Thank you.